Assalamu alaikum. The short clinical station day. First scenario, Mr. Smith, he's 65 years old. Please examine his chest. You can start,
All
Dr.
right.
Henry and Dr. Henry.
Good morning. I'm Dr. Henry. I've been asked to perform an examination. Can I confirm if you are Mr. John Smith, 65-year-old?
Yes, doctor.
Okay. Do you mind if I examine your chest and probably look at your hands and other parts of your body if you don't mind?
Sure, doctor.
Okay. So I sanitize my hands, look at the side of the patient, check for any evidence of corticosteroid card, check for inhalers, check for oxygen, check for IV drip, IV stands, check for, any bracelets, steroid bracelets or anything there.
No.
Then, okay, then I go to the foot of the bed. My patient is positioned, then at his bed up, then at 45 degree. Then look at the chest as into. Can you please breathe in and out for me? Check for the chest
He is doing.
expansion on inspection, anything. Then
From the bed end, if you are checking the patient from the bed end, you can see there is some decrease expansion of the chest on the right side. Right chest wall is not moving equally with the left side.
on the right side, right? Okay.
Yeah.
Okay, lovely. So there's reduced chest expansion on the right. Okay.
Yes.
Then and now look and go in front. Can you please cough for me and see if it's a wet cough or a dry cough or if there's no cough at all?
He's coughing for you and it's a wet cough.
It's a wet cough. Thank you very much. And I look at inspect the chest, check for any scar. Can you please take your hands up, check for the axilla and check any scar, any VAT scar, any scar in the chest and look. Then okay, any scar, no scar. Then I approach the patient, then I look at the patient, then I start to, can you just stretch your hands for me? I check for
Yes,
finger
he's doing.
clubbing. Check for finger
positive.
clubbing. Check for any finger
Positive.
clubbing. Positive.
Positive.
Okay. Any tar stain?
Sorry?
Tar stain. Tar stain. Tar.
Negative.
Negative. Okay. Then check for tremor. Can you cock your hand for me? Check for tremor.
Negative.
Negative. Okay. Then look at the hands. Then go since there's check for the any palmar erythema, then look at any steroid bracelets in the hands or wrist. Then I look at the hands, check for the BP. Look at the palpate the pulse, check for the respiratory rates. Can you please breathe? Okay. Check the respiratory rates. Is it normal? Respiratory rates?
Yes, respiratory rate is 20 minutes per minute, and the blood pressure and pulses are fine. Patient is maintaining on room air.
Okay, fine. Lovely. And there's no signs of there's no evidence of extra accessory muscle of respiration. Okay, now check the BP is normal. Do you have any pain in your tummy? Any pain in your tummy?
Doctor.
Can you please look at the other end for me? Let me check your neck. I check for the JVP is elevated.
Negative.
Okay, then touch down. I want to touch your tummy, please. And then touch and see. Okay, negative. Then can you please use your bring down your eyelid for me? Let me check for pallor. Pallor, any pallor?
Okay. Mild pallor is there.
Light pallor. Okay, then can you open your mouth for me? Check for cyanosis. Any cyanosis?
Negative.
Okay, then look at the neck. Okay, look at the neck and then palpate for the trachea. Is it central?
No.
It's so it's diverted to the right part of the.
Yes.
Okay, good.
Yes.
Then after, can you please sit up for me? Then palpate the lymph nodes from the front, from the back. After I'm done with the lymph nodes, any lymph nodes, then go to the back and then do your expansion. Can you please breathe in and out for me? Check for expansion is reduced on the right.
Okay.
Check for expansion.
First, the lymph nodes are negative, and when you are doing the chest expansion, you can see that the right side of the chest is not moving at all.
Okay. Okay. So then after that, do for middle lobe and then the inferior lobe, the same thing will be all through the. Okay. Any scar at the back? Any scar behind?
I have shared the picture, doctor. You have a picture. Okay. Please see the picture.
Okay, I can't see. Let me see.
Okay.
Okay. Thank you very much. So okay, I think there's okay. Then I'm done with that. Then I'll now check percuss. I percuss my tactile focal for me choose up and down, up and down, up and down. Then percuss, do my percussion up and down in the zigzag manner. Percussion, anything of percussion.
Percussion note is dull.
Done. Okay, at that side too. Okay.
Yes.
Then Then go to the front. And then before I go to the front, I have to auscultate. Can you please breathe in and out for me? In and out for me to auscultate any crepitation. I want the breath sound like.
Okay. The breath sounds are absent in the right side, but when you are checking the left side of the patient, you can feel bibasal crackles.
The right side is the babasal crackles in the right side, right?
Left.
Left. Babasal crackles in the left. Okay.
Mhm.
Why in the right there's absent?
Right is absent.
Right is absent. Okay. Okay. Then okay. Now I'll do the same thing. I'll go to the front. Repeat similar episode. Check for the lung expansion. Check time. Look at the track. Check for the lung expansion. Check for the focal for me to check for
1 minute left.
Then again, go to the back. Then after I'm done with the front and everything, the same thing. Then I want to look at the check for any evidence of lymph node. The hands, the legs. Check for any edema. Then check for any ascites in the tummy. I think basically after I use the left time to gather my thoughts and okay, looking at my patient. So in, the breath sound in this patient is the same thing that's behind was the same thing I can feel in front, right?
Sorry, doctor. Sorry.
I said the same findings posteriorly is the same findings anteriorly,
Yeah.
right?
Yes.
Okay. So
Yes.
and then after I ask person to cough, then I check again after coughing. Any changes after coughing?
The character of crackles is changing after cough.
After cough, okay. All right.
Yeah.
Okay, so I can see a scar. Okay, that's scar. Scar in the right is a scar. Okay, in the left. In the left is capitations are in the left. While in the right is change is absent. Okay. Okay.
Okay, time is up. You want to examine anything else, Dr. Henry?
Okay. Nothing much. Yeah, I'm done.
Okay. Examine your question, Dr. Minan, please.
So please present your positive findings only and give me the differential.
All right. I've examined this Mr. Smith's 5-year-old who on peripheral examination there's bilateral clubbing, and then chest examination there's reduced chest expansion in the right with trachea deviated to the right, and also there's dullness on percussion and absence of breath sound in the right. However, the left there's coarse crepitations. Looking at my examination findings, I'm entertained at my patient, and then there's a scar. There's a scar posteriorly at the right side, which extends from the upwards, downwards along the clavicular region. And then there's also notice a depression, an apical right apical depression, which most likely may be in keeping with phrenic nerve surgery that he has had. And then looking at my whole diagnosis, most likely I'm considering my patient has a condition called bronchiectasis, maybe post TB bronchiectasis because of the evidence of the depression, the apical depression, evidence of apical fibrosis and phrenic nerve scar. That phrenic nerve compression scar that I saw in the apical region. Other differential diagnosis in this case may be due to bronchiectasis from other cause, and other could also be due to lung cancer because of the finger clubbing. So I also entertain lung cancer in this in my as a differential diagnosis too. Then also other differential diagnosis could also be from other occupational related interstitial lung disease like co-worker pneumoconiosis or probably silicosis. Thank you.
Okay. How will you investigate and manage this patient?
Investigation on this patient, I will start by doing bedside respiratory examination. Also, I want to do since my patient is coughing, I want to do is first of all do a sputum MCS, do a sputum AFB. Also, I want to do arterial blood gas in my patient and pulmonary function test in which I expect to see a restrictive pattern in my patient. And then I want to do a chest X-ray to further see there's evidence of nodular changes and then any evidence of nodular changes. Then I want to do CT scan or high resolution CT scan, in which in this case I expect there may be some traction broadcastesis in that axis, and then also if it's evidence of broadcastesis, I expect to see signet ring or tram tracking on chest X-ray, and then signet ring on high resolution.
How will you manage this patient?
Management of this patient will involve the multidisciplinary approach, in which to involve the pulmonologist, the respiratory chest, the chest physiotherapist, the occupational therapy, the specialized nurse, and also dietitians. And basically, it also involve other social services if need be. Patient will be at this point in time, since he has had we want to establish, depending on the line contributed to TB. I want to check if the TB is active or if it's recurrent. Then treat the TB with the medical therapy by giving the RIPES, the rifampicin and rifampicin isoniazid, pyrazinamide and ethambutol for 2 months, and then continue the other 4 months and give the either rifampicin and isoniazid. Then do continuous monitoring and check for the liver function test to monitor the side effects of medication. Then I want to do the serial pulmonary function test, also advise the patients on likely disease condition, then advise us to stop cigarette smoking if need be, and then counseling on further dietary management, and also, and this if you also benefit from further surgical intervention, you may need to approach. Thank you very much.
Okay.
Any other question, Dr. Mina?
Okay. So, can you tell me that according to your findings, what a procedure must have done through this procedure, through this scar? What do you think?
Most likely, may have done some phrenic nerve, phrenic nerve procedure.
Other than that, the findings you find in the whole right-sided chest, any other thing?
Yeah, in the whole, based on the fact that it's absent, it could be due to has had a pneumotomy done, a lobectomy done, or a lobectomy or pneumotomy may be done in this patient.
Okay. Sir?
You're done, Dr. Mina?
Yes, sir.
Okay. He managed the case? Did you ask about the management plan? If this patient present to you with a short breath, what you do?
Sir, you're asking me or him?
No, him. Did he manage? Did you ask about the management?
Sir, he told me some plan of management.
Okay.
Yes,
So you're done? Yeah, okay. And now you can comment, Dr. Mina, then I will comment.
Okay. Yes, sir, it was a case of suspected case of bronchiectasis, and few things I would like to comment that I don't know if the doctor has checked the apex beat in this patient or not. I'm not sure about this, that if we locate the apex beat in this patient. Other than that, I could not get any comment on vocal resonance in this patient, and other than that, about sacral edema. While I was okay with all the steps he done.
Yes, I agree about the Cartagnar as one of the cause of bronchiectasis. You have to check the apex beat. Not only in this scenario, in every chest scenario, do the apex beat. It's one step also, one step only. Examine or palpate the apex. If you could palpate it, it's okay. If not, you can auscultate in order not to miss the Cartagnar syndrome, okay? This is very important, Dr. Hinay. Don't miss it. Otherwise, I don't know why you mentioned the phrenic nerve. Why Can you tell me what's the idea behind that?
Yeah, the scar is looking like a phrenic nerve scar compression,
I don't think in PACES they will bring phrenic nerve decompression scar. Right?
Okay.
So what's the common presentation of this scar? What could be this scar for?
It could be dead for pneumonectomy, basically
Exactly.
pneumonectomy.
Yeah. So why you are going for very rare condition, which is the phrenic nerve decompression, for example, and you have very common presentation, which is pneumonectomy, right? It's a classic scar of pneumonectomy, extending from the right to the from the anterior to the posterior, parallel to the chest wall, right? So
Yeah.
ideally, this is a pneumonectomy scar.
Just because of the anterior findings, anterior findings, it looked more
No,
like a
no,
phrenic nerve.
no,
Anteriorly.
even the anterior finding going with the pneumonectomy, patient with no lung on this side, so the expansion will be less, the percussion will be dull because no lung there, right?
Yeah.
I'm not sure about the phrenic nerve as a case really. It needs some
Sir,
thoracic surgery or pulmonology. Yes, Dr. Minam, tell me.
so this is a simple case of posterior lateral thoracotomy scar leading to
Yes,
pneumonectomy. So
yeah,
no information on recurrent here.
yeah. That's why I'm saying to him it's not. Maybe even wrong scar. I don't know really about this scar. That's why I said it needs a doctor of pulmonology or thoracic surgery to know the scar of phrenic nerve. However, nowadays they can do any scar, any manipulation, any procedure with laparoscopy. So they can go VATS. They can do VATS and they can approach the phrenic nerve without this major scar. So ideally, this scar will be for pneumonectomy. I don't think other any procedure can fit apart from pneumonectomy. This is my opinion. Otherwise, the steps you miss the apex beat is very important. The good thing here, you ask the patient to cough after healing the crackles. It's very important. The crackles will be changed. The character will be changed always with the bronchiectasis. Let's let's have another question, Dr. Henry. What are the differential of coarse crack? Do you know?
Of course, Kakus. Yeah. Thank you very much. The differentials for quartz Kakus may include bronchiectasis, like in this patient. It may also include pneumonia, pneumonic changes, pneumonic changes, like seen in consolidation. Then it could also be due to other quartz Kakus, could be due to I think basically pneumonic changes. Also, in some case,
One more, please. It's very important to mention.
yeah,
Coarse crackle. You can hear it.
quartz,
Yeah.
yeah, you can see quartz crackles in sorry, no.
No worry. Take your time. Others can write in the chat box the three differential of coarse crackles.
Pneumonic changes,
Okay,
bronchiectasis, and
you mentioned pneumonia. What else?
yeah, it could be due to TB, which is also pneumonia to tuberculosis. TB,
No. TB as a fibrosis.
abscess,
Abscess. It will not be
cancer,
with the coarse
malignancy.
crackles. No. I'm talking about coarse crackles. Coarse crackles. Where and when you can hear coarse crackle? No, it's not TB, not fibrosis. Fibrosis will be fine basal crackle.
I didn't say fibrosis. I said cancer, malignancy.
Even malignancy, it might be a mass with no crackles. You can say bronchial breathing, but I'm talking about coarse crackles. Anyone commented? Yes, heart failure. Dr. Mina mentioned heart failure and pulmonary edema.
I
Not
think
only
a heart
heart
failure is
failure.
not fine.
Not only heart failure, by the way. A heart failure, it can lead to by basal crackle
Yeah, heart failure is fine by
initially.
basal crackles. It's
But when
fine.
you,
It's not coarse.
yes, no, I'm not saying, no. I said coarse crackle for pulmonary edema. Okay?
Okay.
Pulmonary edema, as a
All right.
coarse crackle, you can hear it even without a stethoscope. Are you agree?
Yeah. Okay.
Yeah.
I
Okay.
agree.
So we are talking about three conditions: bronchiectasis and pneumonia, lobar or diffuse pneumonia, and the third is pulmonary edema. These are the cause and differential, of course, crackle in bases. Okay?
Okay.
It's not only
Okay.
heart failure, Dr. Minan. You should specify the pulmonary edema. Okay, other question I will ask you, Dr. Henry. You mentioned specific investigation, right?
Yes.
Yeah, what are the most important specific investigation here to conclude the case? Specific.
Specific investigation here. I mentioned pulmonary function test, which is
Okay.
spirometry. Yeah, I also mentioned high resolution CT scan.
Okay.
Then in this case too.
If you
Yeah.
want to investigate for the cause of this bronchiectasis case.
For the likely cause, I want to do sputum AFB and then sputum gene expert. If need be,
Okay,
then
perfect. This is to know the underlying infection. Okay,
yes.
what if you want to know why this patient is having frequent infection? How you can investigate?
Yeah, if it's an elderly patient, we want to do or check for other autoimmune cause, autoimmune profile, do inflammatory markers like CRP and ESR. Then also this is for also we need to do blood culture for him. Then
Okay, I will ask what causes of inherited cause of bronchiectasis? Do you know?
yeah, for young patients, want to do like think of cystic fibrosis, which is common in the young people, not this in this age group. But however, if it's a young patient and it's come down with this condition, I'll do your stress test for for the cystic fibrosis. Then do a cystic fibrosis, a genetic study such as cystic fibrosis
This is what I want you to say. The genetic testing. Okay. So
Okay.
for either bronchiectasis, due to cystic fibrosis, I can confirm it by the genetic testing. Okay, what other tests specific for cystic fibrosis?
Yeah, sweat test, sweat.
Okay, I mentioned it earlier. How much the number of the chloride test should be?
Yeah,
How much?
60.
More or
More
less?
more than 60.
Okay. Okay, well done. Okay, thank you, Dr. Henry. I'm done with my comment. Dr. Minam, you can comment now. Okay, you commented, right, about the
Yes,
performance?
sir. Yes, sir.
Yeah,
Yes.
okay. Dr. Henry, please, you can prepare a case or you have prepared any case?
Yes. I'll send them to you now.
Yeah, okay. Open discussion now. Anyone want to add any comment? Any differential? Any missing points?
Hello.
So I've sent them to you. The image, the case is a 35-year-old man came for regular checkup in your clinic, examine the cardiovascular system.
Sir, should I start?
Yes, I will set the timer. I receive the picture. I will share it to the chat box whenever you start, okay? So you are
So
going to
this is
examine? Yeah, 35 years old, John
35,
Smith,
35. Sorry.
25,
35.
okay? Yes.
35, yeah.
Yes, here you go.
it's a cardiovascular examination,
Yeah,
right?
cardiovascular. You can start now.
Okay. First, I'll enter the room, greet and sanitize my hands, and I would like to take permission from the patient that I'll be doing your examination, your heart examination. If you feel any pain and discomfort during the examination, please let me know.
Okay, doctor.
Okay, then I'll move to the bed end and I'll ask the patient to take a deep breath, and then I'll move to the right side of the bed and I'll take the permission from the patient to undress or unwrap. Then I would like to see both the hands of the patient by putting both the hands on my hands, and I would like to see for any clubbing. Any nail changes?
No,
Any
no
splinter?
clubbing, no splinter hemorrhage.
Okay. Then I would like to feel the palms of the patient for any skin changes, specifically any oscillatory nodes, any Janway nodes.
No.
Okay. Then I would like to feel the pulses of the patient for regularity and volume. First for the radio-radial delay, and then in one hand for the regularities and volume.
Okay, no, normal.
Okay. Then I would like to check for the collapsing pulse by asking the patient if he has no pain in the shoulder. Then I will proceed with the collapsing pulse.
Okay, normal.
Okay. Then I'll ask the patient to see the left side of the wall. So, and I'll take the permission if he has any pain in the tummy. I'll press the tummy and I'll see for the hepatojugular reflex in the patient.
Normal.
Okay. Then I'll ask the patient to pull down the lower eyelid so I can see for any anemia. Then I would
No.
like to see the mouth of the patient for any dehydration, for any sores, for any cyanosis, for jaundice, anemia in the mouth.
I've shown you the mouth.
Sorry?
I've sent the picture. Yeah, go ahead.
Okay. 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 And then I would like to, I'll inspect the chest of the patient, and then I would like to feel for the any apex beat. I would like to feel for the apex beat with my right hand. And
It is normal.
is there any character or any displacement from the fifth
Yeah,
left
no,
intercostal?
it's normal. No displacement. It's at the fifth
Oh,
intercostal space. Yeah,
okay.
midclavicular
Then
line.
then I would like to check for any systolic thrills, any parasternal heave.
Yeah,
Then I will check for.
okay.
Sorry.
There's a click sound you can hear at the, yeah, there's click at the apex. You can hear some click sound at the apex too. Mm.
Okay, so I would like to correlate the click with the first sound by putting my left hand in the carotids, and I would like to feel that if it's going with the S1 or not.
Yeah, it comes with the S1 and then after the X1 too.
So it's going with the S1.
S1, both at S1 and after X1, but more with the S1.
It's with the S1. Okay.
Mm.
Then I would like to check in the left sternal edge for any sounds, any added sounds. Then I would like to check in the pulmonary area as
Yeah,
well.
you are seeing the click too. You are hearing the click all over.
Okay. Okay. And then I would like to check in the right second intercostal space for the aortic area as well for the
Yes,
sounds.
yeah, you are hearing the click too. This time it is louder after the first sound.
It's louder. Is it going with the first sound as well?
No, it goes with the first sound and after the first sound, but you hear it louder after the first sound.
Okay.
Mm.
Okay. And then I will ask the patient to sit up. I'll keep the stat on the chest of the patient. I'll ask the patient to sit up, and then I'll keep my left hand in the carotids. I will again check all the four sides in the patient
Yeah, the same
by
click.
asking the okay, by asking the patient to sit forward, take a deep breath out, and then I'll ask the patient to take a deep breath in, and I'll auscultate in the all four areas. I'll then check the carotids with the bell, anything I can hear in the carotids. And then I would like to check for the basis of the lungs for any basal crabs, and then for any sacral edema. And then I would like to feel for the pedal edema by looking at the patient if he feels any pain or if it's any pedal edema there.
Okay. No pedal No pedal
Okay. I would like to complete my examination by offering for the blood pressure and urine dip in this patient.
Okay. Blood pressure normal. All right. Thank you very much. You have 3 seconds more.
Okay.
Any
Heavy
that you want to do? Have you
1
seen
minute
the
left.
picture? Have
Yeah,
you seen
there's
the
picture
picture?
in the chat box. You
Okay.
want
Any
to
that you
add?
want to do?
I've
Yes.
just seen it. Yes,
Yeah,
sir,
you
I've
can
just
see
seen it.
now. I just shared it. Sorry, but you didn't ask earlier. That's why I didn't share. Now you can do the examination appropriately. What you will do?
Sir, in the mouth, like I will check for any high arched palate and any gum deformities as well. And in inspection, I would like to inspect the scar and any drain marks I can see now. So, and
Yeah, what other test you want to do? Now you have realized this patient with specific character. What you want to add to your examination steps?
sir, I will inspect the scar and
Okay. What else?
I have then in the mouth I have will seen for any high arch palate in this, and then
Okay.
okay, then he told me about two clicks. I think one is going with the S1 and other is not correlating with the carotids. I think so.
Anything in the hand you want to do?
Sir, in the hands, I will check for any particular shape of the hands, any elongated fingers or
Okay.
any
Yes.
hypermobility or hyper. So that I
Yes.
will see, but because I cannot see the
Okay.
hands, so I cannot comment right now.
Okay, good. Okay. But you know the specific test for our case today, right? Okay.
Yeah, okay,
Uh,
so the the
yeah.
the wrist sign and the thumb sign I'll do.
Perfect. Perfect. Yes. Okay. The
Yeah,
time is up,
Okay.
Dr. Henry. You can start the exam question.
All right. Can you mention the positive findings in your patient and likely diagnosis and differentials?
so I have examined this patient, and the positive sign I can see that in the mouth the patient has a high arched palate, and on auscultation I can hear a click in the mitral area, which is coinciding with the S1, and I can also hear another click, which is louder and not going, which is after the S1. So other than that, I cannot correlate anything. If I have seen the hands, and there could be any elongated fingers, then if I like to do uh, thumb sign test and a wrist sign in this patient. So I believe this patient has a dual valve replacement done with a median sternotomy scar with two drain marks.
Okay. So what are the underlying causes of the 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 surgery?
So
Uh,
the surgery could
differential cause of the surgery.
it could be underlying mitral rigors or aortic rigors could be one of the possibilities. It could be mitral valve prolapse within aortic rigors, and it could be yes, these are mine.
Okay. What then? How do you investigate for these patients?
So I would like to do investigations in form of complete blood count, the kidney function test, and inflammatory markers. Specifically, I would like to do an echocardiogram in this patient, ECG, X-ray chest in this patient, and other than that, I would like to go for complete urine routine examination in this patient and coagulation profile, including the INR, PT-INR in this patient as well. And I would like to, uh, yes, and that's it.
Okay. So how will you manage this patient?
I would like to manage my patient by education, counseling, and explanation, making a multidisciplinary team, which will include a cardiologist, specialized nurse, and INR clinic nurse as well. And I would like to keep my patient on regular echoes, follow up with regular INR checkups. I would like to keep a check on the blood thinning levels of this patient as well, and review of medications, dietary follow ups as well, and looking for any underlying uh, complications. If the patient is going on, then I will like to treat it accordingly.
Okay. So looking at these patients, you say your patient is having high arc palate, right? So what are the
Yes.
differential cause of high arc palate in this patient? Like differential cause.
So I would like to keep first Marfan syndrome. Second, I would like to keep Ehlers-Danlos syndrome. Third, I would like to keep osteogenesis imperfecta. Fourth, I can like to keep homocystinuria for high large palate.
Okay. So
Yeah.
assuming this patient is having a
Hmm.
okay, let's say assuming this patient is having pallor, what will be the likely cause of the pallor in this patient?
So there could be many causes, different causes of failure in this patient. First, it could be a warfarin toxicity, could be one of the reasons in this patient. Leading to, other than that, anemia, valve incompetence, can be vasculitis in form of infarctive endocarditis. And yes, I would like to keep these as causes of failure in this patient.
Okay. And
Yeah.
basically, if this patient coming presenting with
Sorry?
short, if this patient
Mm-hmm.
coming probably in some few weeks time, and then presenting with, let's say, shortness of breath,
Mm-hmm.
what would be the differential diagnosis of the likely cause of shortness of breath in this patient?
Valve thrombosis.
Okay.
Yeah.
1, 2.
Other could be valve stenosis can be there as well. Heart failure can be a possibility as well. It could be infective causes like infective endocarditis. So in this way, I would
Okay.
like to keep. Yeah.
Beautiful. Okay. All right. Thank
Yeah.
you very much. I think it's almost time.
Thank you.
All right.
Thank you.
Okay.
Okay, thank you, Dr. Renee. Well done. 5 minutes already. You can comment now, then I will comment.
All right. Yeah, it was a good examination. It was a good, but my own comment is that you did very well. You didn't sanitize your hands after examining your patients before. When you are done, you should have sanitized your hands. Very, very good. After and before and after, Then also you didn't check the leg for vein harvesting scar.
Sorry?
You didn't check the legs for vein harvesting scar. Usually, when you see a meat, make it as
Yeah,
a
yeah.
practice. Look at the leg, check for vein harvesting scar. You didn't check it, did you?
I think I didn't mention that.
Yeah, because you didn't check it. You didn't mention, so you didn't check it. So because it's once you say median sternotomy scar, you should go to the leg and check for the vein harvesting scar, because it can be due to CABG, may also be a differential
Yes.
diagnosis in this case. And also other differential diagnosis of this midline sternotomy scar, you mentioned it could be due to valvular repair, valvular replacement, could be due to congenital heart replacement. Most of this patient is a
Yeah.
young patient, 35 years old. You said?
Sorry?
You said something?
You are asking me something, I think.
No, I didn't ask you something. I said, when you say medial sternotomy scar, it
Yeah.
might be, if there's a maybe from, like I said, it can be a valvular replacement, a valvular repair, a repair of congenital heart disease. Being that this patient is a young patient too, you think of that too. It could also be, a heart transplant.
But
That
you
can have.
didn't ask me for differential for median stenotomy scar. You asked me that what is the cause of median stenotomy scar in this patient. So I give that. There could be other causes. Thymectomy can be done through that as well. Pericardectomy, stripping can done that way as well. Could be
You did
many other
mention it now.
causes.
You did
But
mention that.
I mentioned for according to the patient, not for the indications of median stenotomy scar itself.
Now, yeah,
I
this
was checking.
patient with mitral valve, with Marfan syndrome, could also have, heart, also congenital heart. You could also have what do you call it, CABG. It's possible. You could also have, other congenital heart disease, like why
But the
you could
patient
have.
has click. Why a CABG patient have a click? This patient has a click.
So
So you
a CABG patient with mitral valve, because usually before you do a mitral valve, you have to do your coronary angio to check if there's, before you do any valve, you have to check. It's possible that the person may have
okay.
it's
But
possible.
I gave according to the only for the differential of the patient, not for the median stenotomy scar itself.
It's
So I
okay.
Because
just
you
It's
gave
okay.
according
have
to
Just
the
to
to
do,
know,
patient.
yeah. Just to know,
you have
Dr. Minam,
just
to know the all views, okay?
your view, but
Yeah.
you didn't check. You didn't check for the leg. As when you check for the leg, I would have shown you the leg that has,
Yeah. Yeah.
but you didn't check.
Yeah.
So you've missed that part,
Yeah.
that findings.
Yeah, make it as a habit whenever you are examining the leg or the feet, examine for the scar of the
Yeah.
harvesting scar, okay? That's it. Okay, continue, Dr. Renari. What else?
All right. So, and also, basically, for the when you mentioned about the there's something I also want to say. I've forgotten. I've forgotten what I wanted to say now. You know. Oh gosh, why did I forget this thing?
It's okay. Take
Okay.
your time. Take your
All
time.
right. Okay, you for the I also asked the next question I asked was the issue of you got the other ones, the causes of anemia, shortness of breath in this patient. This also other causes of shortness of breath in this patient, being that you're suspecting that he has Marfan with cardiovascular symptoms, could it also be from respiratory symptoms too? After I've
Sorry,
mentioned the
sorry,
cardiac symptom, pardon?
so I didn't get which symptom.
It could also be from respiratory problem outside cardiovascular problem for shortness of breath.
Yeah.
It
Okay.
could be due to
Yeah.
pneumothorax. You understand? It could be due to pneumothorax, pneumonia and some other things that can also cause shortness of breath in a patient, especially in Marfan's syndrome that they are prone to pneumothorax. Basically, they might come, especially you've handled, it can be due to valve failure or probably infective endocarditis, like you mentioned, which are good ones. You did very well. Just to add, in case probably the examiner is still asking what next, you can see add other respiratory cause in this piece. Then actually it was a good one generally. Thank you. I've forgotten the other things I wanted to say.
Yeah.
Thank you.
Thank you, Dr.
Mm,
Nari. Thank you,
mm,
Dr.
mm.
Inam. I will ask you one more question. What if you have pallor in this patient? You mentioned anticoagulation side effect or supratherapeutic anticoagulation, right? What other possibility you mentioned?
So it could be
Infective
um
endocarditis, right? You mentioned
yes,
infective endocarditis. Okay,
yeah,
hemolysis. What
yeah,
else?
hemolysis
Particularly
and
in this patient, he had a scar for, let's assume, replacement, right? And
mm,
most probably, he had replaced aortic or aortic valve replacement. Why? Because mostly they have aortic root dilatation. So it
mm.
could be there as aortic valve replacement. What do you think the complication might happen and can lead
So
to
that could
anemia? Yes.
Haydee
Yeah,
syndrome.
exactly. So yeah, a hemolysis on the
Yes, sir.
and the valve,
Yes,
and
sir.
it could be another reason. So one of the investigation, and it's very important to mention in this scenario, the coagulation profile, right? Did you
Yes,
mention?
sir. Yes, sir. I mentioned
Okay, how much the target INR in aortic valve
Yes.
replacement?
Yes.
The target.
so our target is between 2 to 3.
Perfect. Okay. What if he has mitral valve prolapse and he had another replaced mitral valve? How much the target will be?
Um, so it's between 2.5 to 3.5.
Perfect. Okay, that's it. One more, the short breath. Yes, he mentioned some chest causes. However,
Yes,
this
sir.
is a cardiovascular case, so he will ask more about the cardiovascular causes. What you
Mm,
mentioned, infective endocarditis, right?
mm.
Thrombosis or dysfunction of the valve, and heart
Yes, sir.
failure,
Yes.
right?
Mm.
What else you can add as a cardiac?
So it could be acute coronary syndrome can be considered.
Okay, yeah, because of aortic can affect the coronary,
Yeah.
aortic regurgitation or aortic root dilatation. Okay, yeah, I think well done, Dr. Minam. You covered the whole topic as the presentation. However, I share the photo late, but because you didn't ask. But I
Mm.
think it's spot diagnosis. The lucky doctor
Yes, sir.
who will have the scar. Scar means you have to know the scar and to mention what
Mm.
is the surgery and what is related to the surgery. So, what are the possible cause of mid-sternotomy scar in Marfan patients? This is the last
Sir,
question. Dr. Minam. Yes,
yes, sir. Sure, sir. Sure, sir. So, sir, it could be a surgery for aortic dissection. Could be one of the
perfect.
possibilities.
Yes, you didn't mention it. Okay, what else? What else?
And what else? It could be, sir, for surgeries for any aortic root dilatation, as you said.
Yes, yeah. So replacement of the aorta, replacement of the mitral replacement, and the
Mm.
last is, as you said, aortic dissection.
Aortic
Okay?
aortic dissection. Yes, sir.
Yeah, you can add coronary artery disease, and
Mm.
could be also cabbage. That's why Dr. Hinary is advising you. take care of the harvesting scar in the leg. Okay.
Yes, sir. Thank
Yeah.
you. I will
Oh,
definitely, inshallah.
okay. Yes. Okay. Thank you, Dr. Minam. Dr. Henry. Anyone want to add any comment or question? Definitely, whenever you have Marfan patient or you suspect a Marfan patient, you have to say, I would like to complete my examination, examining for the features of Marfan. In the form of, you can say the lens dislocation upward, the tall stature of the patient, along with the finger thumb and wrist test, and already done by Dr. Mina. Okay. Don't
Okay, sir.
forget to put this patient under surveillance for aortic root dilatation. It's very important because they have a very high risk of having the aortic dissection. Okay.
Okay, so
And
sir,
also,
there is
Dr.
any
Basil, Dr. Basil,
Yes. Yes.
just to add, this patient, if you look at the scar very well, you can see that there are three drainage scar there beneath the sternotomy scar.
Okay.
So you should have comments on the three drainage scar. Most likely it might be a dual sternotomy.
Okay.
Yeah, because sometimes this examiner wants to mention the three drainage scar he has beneath the sternotomy scar. Most likely he has one of them appear to be far healer than the other, as in older than the other. The two appear recent, one appear older. Most likely this patient might have had a dual or probably double median sternotomy. Very
Okay.
possible.
Okay.
So you have
Yeah.
to consider that as a differential diagnosis. When you see the drainage scar, if it's more than two,
Yeah. Yes.
you may be due to what a double or repeated sternotomy. The other ones may be
Yeah.
so
Yeah. Yeah.
very
So
possibility. Thank you.
okay. So you mean every sternotomy will have port drainage scar, and he has two drains scar. It might be two sternotomy scar on the same scar, right?
Yeah,
This is what you
yeah,
mean. Yeah.
yeah.
Good to know and good to mention because those patients they will have either aortic or mitral or both of them.
Yeah.
Perfect. Thank you, Dr. Hinay. Okay. Thank you, Dr. Hinay, Dr. Minam. Anyone want to add any question or want to ask anything?
sir.
Yes, Dr. Minam.
Sir, you said that keep the patient for surveillance for aortic root. So, sir, there is any specific time like 3 monthly, 6 monthly,
No,
any
no,
idea?
annually. Annually.
Annually. Okay, sir. Thank you
Yes.
so
And
much.
they are
Thank you, sir.
measuring the
Thank you.
aortic root diameter frequently. Yeah.
Annually aortic root diameter. Thank you, sir.
Yeah.
Thank you so much.
Most welcome. Thank you, Doctor.
And also, sorry,
Yes,
just to
continue.
add, Dr. Pasi,
Yes.
regarding the surveillance for aortic dilatation, it is said that if the dilatation is more than 3 millimeter per year, it's an indication for replacement.
Yes, yes. So it's not only the valve regurg or aortic valve
Mm.
regurg, even
Mm.
the enlargement of the root, it's an indication to do the
Mm.
replacement. You're right.
Yeah.
Okay. Thank you, Dr. Gabriel.
Thank you.
Anyone else want to comment? Any question? Okay. Thank you, Dr. Minam and Dr. Henry.
Thank you, sir.
Thank you so much. Thank you for the attendance, everyone who's wrote also in the chat box. Sorry if I missed some of the chat box. I received some calls in between. That's why I was interrupted. Sorry. Anyway, have a nice weekend. See you inshallah in the next week. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.